The director of the IU Center for Bioethics, and it's my great pleasure to welcome you to the IU Bioethics Grand Rounds today. We have these regularly. We actually have 2 or 3 more events hosted by the center on the topics of bioethics, bringing the community together for learning and discussion. This fall, please go to our events page, and you can see that, or you could open our newsletter, our first ever IU Center for Bioethics newsletter, which was sent out yesterday, and that has a list of the upcoming events also. Before I even introduce our speaker, I will say thanks to our staff. It is Staff Appreciation Day. This should always be the case, though. Nick and Seamus, yes, right? Okay, bringing us together here, and for those of you online, thank you for being here, and thank you, Nick and team, for bringing us together here. It is my pleasure to introduce Professor Craig to you. He is most importantly a faculty investigator at the Center for Bioethics, and has been for a bunch of years, and really has been wonderful here. I think Professor Craig is one of those people who makes the study and work on bioethics here in Indianapolis and at IU so exciting. People coming from a whole range of backgrounds with a whole range of research interests, and often mixing, as Professor Craig does, theoretical work, deep, important theoretical thought with empirical work, and even activism and intervention in the community. So Professor Craig is Professor of Religious Studies, and he is an Associate Director for Community Health Partnerships at the Indiana Clinical and Translational Sciences Institute. Professor Craig received his Master's in Theological Studies at Harvard Divinity School, and then his Master's and PhD in Religion at Princeton. He's a religious ethicist, and I'm going to say in a number of areas, but especially in healthcare. His book, Healthcare as a Social Good, explored framing of healthcare in important ways, and in ways that are very common in our society, both as a private benefit, as a private choice, as a public right, and then also as a social good. I think we'll see that theoretical work, and that result of that was empirical work also based on conversations, but we'll see that in his current work. The work that he's been doing lately that I'm so excited about, I've been begging him to come and talk to us about, has been a community-engaged work through the Healthy Indiana, about the Healthy Indiana Plan, through the Indiana CTSI and the Monon project collaboration, to work with congregations in Indianapolis and create community impact hubs that bring local knowledge and health assets to improving health outcomes in underserved communities. And so with that unfortunately long introduction, which I could not shorten, Professor Craig.
Thank you very much, Peter. I appreciate the introduction, and Nick, I appreciate all of the work you've done making this happen today. I just want to say, by way of starting, I am indebted to Peter for this project in many ways. He showed up in my office in January 2018, and he challenged me in this very nice, encouraging way. Like, what do you really want to do right now? And I was like, well, if you ask me what I really want to do right now, I want to study Indiana's Medicaid expansion, the Healthy Indiana Plan, to see how it's working or not working. And I want to do this with community partners in community. And Peter said, let me introduce you to Sarah Weehee and Gina Claxton at Community Health Partnerships. And this has transformed my research and really changed how I do my research. So thank you, Peter, for that. So what I'm going to do today is I'm going to talk about my research. But just to preface this, I have to point this way, I guess. Why is this not working? Which way should I press? Here we go. We'll do it this way, hopefully. Okay, nothing's working. Okay, try now. Okay, still not. There we go. I'll do the slide clicks. Okay, great. So I just want to preface this with a question. And this is a question from my perspective. People may disagree, but why is the topic of health insurance and more specifically Medicaid coverage not more of a regular focus of bioethics in the United States? I find it's very much an under-discussed topic, especially given that Medicaid covers almost 80 million people in the United States and pays 1 in 5 healthcare dollars, just to give a sense of its very large scope. So what I want to do today is I'm going to reflect on this I'm not going to reflect on that question so much, but I want to think about the term autonomy, which I think is partly a barrier to why we don't think about Medicaid. I'll come to that eventually. But I want to share several ideas of autonomy to indicate what I see as shortcomings in its use as a central principle of bioethics. So that's what I'm going to do. I'm going to put autonomy in 3 different settings to try to think how we theorize autonomy in different settings, because I think how we theorize autonomy affects how we understand people and care for people. Okay, so the first setting is kind of the standard bioethical view of autonomy. The second setting is how autonomy is talked about in terms of the HIP program, because HIP was actually designed around a concept of the autonomy of healthcare consumers. Different ideas of autonomy, different settings, but I want to suggest there's actually maybe a little more resemblance than we might think. And then I'm going to say something about our research as to why HIP doesn't really meet the criteria of autonomy, even as it's specified. Okay. Then I'm going to try to talk about autonomy in the context of our community valued research, the research that we've done around HIP. So I've got a lot of territory to cover, but hopefully I can give sort of 3 snapshot views of autonomy to suggest some of the limitations and how we might think differently about autonomy and agency in bioethics. So that's what I'm going to try to do. Parts of this talk are going to move briskly, and other parts I'll slow down a little bit more. So this is a brisk part of the talk, the concept of autonomy. Autonomy has a lot of different historical sources and trajectories. I think in terms of how we think about autonomy today, close cognates are self-government or self-determination. So this is sort of a general definition of autonomy, not specific to bioethics. We're always interested in competent people. So we set aside some people, especially minors, as not competent oftentimes. But a competent person's rational free capacities decide and act in line with one's self-concept. And I want to really emphasize that idea of self-concept, because autonomy means giving oneself the law, right? And, it's a simple idea of self-concept, consider desires, goals, and values. Okay. In bioethics, this tends to translate to something like this. A competent person's informed, rational, free choice in making medical treatment and research decisions in line with one's self-concept. And I sort of put that in parentheses because I think it's still there, but maybe not quite so prominently. All right, but autonomy in bioethics is not just a patient's exercise of autonomy or a research subject's exercise of autonomy. It's respect for autonomy. That's really what we care about in bioethics, right? It's professionals' respect for people's autonomy. So here it becomes respect competent persons to make their own medical treatment and research choices by providing full unbiased information and by protecting against coercion. This is how we typically think about autonomy, I want to suggest, in a kind of bioethical context. I'm drawing here very much from Beecham and Childress's sort of classic text. And one of the things they say is respect isn't just an attitude, it's an act. It requires things of the professional, not just an attitude, but it actually requires actions. So what do those actions include? I want to suggest in the clinical setting, respect for autonomy requires supporting a person's liberty and agency, right? This is very much how Beecham and Childress talk about it. Individual protections, you have to give full unbiased information. You have to avoid coercion. But there's also another level, which is some degree of health promotion in line with the person's self-concept. And we see this particularly in refusal of medical treatment. When a person refuses medical treatment in line with their self-concept, providers actually have to do things. Okay, so I want to say it's there, even though it oftentimes may not appear quite so prominently. Now, this is not the only setting. The clinical setting isn't the only setting where bioethicists think about autonomy. It also applies to health research studies and the wider health industry. for example. I want to suggest that here, respect for autonomy tends to be limited to informed consent. It tends to be minimized here. So yes to individual protections, full unbiased information, and no coercion, but health promotion becomes sort of the potential benefits for the general population. For people who write IRB protocols like me or study information sheets, there's usually this really vague promise of benefits to a general population beyond financial compensation that a participant might receive. But it doesn't really redound back to the participants typically, I just want to say. Okay, so this is my stage setting, just sort of talking about bioethics in the context of, autonomy in the context of bioethics. Okay, what I'm going to do now is talk about autonomy in the context of the Healthy Indiana Plan. I'm going to give a really truncated, brief, fast view of HIP and where we are today, okay, just to set this up. All right. So here's a quote from former Governor Mitch Daniels. That's very much in line with the Healthy Indiana Plan. You either believe in personal responsibility or you don't. Simple as that. Okay. So HIP, created during the Daniels administration, centers around the idea of personal responsibility and personal wellness. These are the central values of HIP. Okay. So it was originally launched in 2008 as a small demonstration project with 40,000 enrollees. What was interesting about it at the time is it had innovative incentives for personal wellness. It actually offered vision and dental coverage, which was very unusual in Medicaid programs at the time, right? So long as members navigated personal responsibility incentives. So their personal wellness incentives, their personal responsibility incentives built into HIP. In 2015, Indiana got a waiver from federal government to use HIP as its vehicle to expand Medicaid in Indiana. So it got certain permissions to do things differently than traditional Medicaid and also changed the HIP program in important sorts of ways. Importantly, it retained the personal wellness and responsibility incentive structure. Because of the Affordable Care Act, now there's a 90% federal match rate for everybody on HIP, and it grew to over 400,000 people. So big transformation, even as the incentive structure remains largely the same. Okay, don't do that. Sorry, got to right click. Okay, so at this point, HIP, in terms of enrollment numbers, is the second largest program in Indiana Medicaid. There are the four others that exist. And just to give you a sense of who's eligible for HIP, these are the income eligibility for HIP up to 138% of the federal poverty level. So basically today, single individuals making up $20,000 qualify for HIP. Couples at 28,000, family of four at 43,000. You can see this is much higher than the minimum wage here in Indiana. So a significant subset of the population. Okay. So now what I want to talk about is HIP's incentive structure. And I'm going to do this very briefly and quickly, but HIP has multiple tiers. When you apply for HIP and get accepted to HIP, you are invited to be on HIP Plus. Okay. And HIP Plus is fairly comprehensive benefits. As you can see, medical, prescription, vision, dental, chiropractic are covered. There are no co-payments except for repeat use of the emergency room, but basically no co-payments for anything. And all of this is covered so long as you pay your monthly power account contribution, which can be either from $1 to $20, depending upon where you are on that income scale. Okay. I have no income. I got to pay $1 a month to get my full benefits. Okay. Yeah, I saw that question of how do you do that? That is one of the big questions. If you don't do that for 2 months, you are downgraded to basic. Basic has medical and prescription coverage, no vision, no dental, no chiropractic, and it has co-payments for every single visit, every single medication. So suddenly the coverage has gotten skinnier and the barriers have gone up. Okay. This is what happens. Now, people earning up to 138% of the poverty level can qualify for HIP Plus, but basic is only for people up to 100% of the federal poverty level. So some people lose coverage if they don't pay their power accounts. Some subset loses their coverage, okay? There are 3 other tiers of HIP: HIP Maternity, HIP State Plan Plus, and HIP State Plan Basic. There's a lot of detail I'm not going to talk about here, but you can begin to get a sense of the program complexity and some of the incentive structures. I hope this is at least clear enough. I gotta always remember to left click. Okay, so HIP was changed by the pandemic radically. The CARES Act gave states more money if they kept people enrolled on Medicaid, and Indiana stopped cost sharing. Indiana stopped premiums and stopped co-payments on the plan. So it became a very different plan. And that actually remains the status quo today. There is no cost sharing in HIP today. What happened? Enrollment skyrocketed. And even a year in to annual redetermination, when people had to show they were still eligible, the numbers were much higher, 700,000 compared to 400,000, than they were at the start of the pandemic. The current number is just below 600,000. 90,000 people have lost coverage since the start of the new administration. Okay. So I'm just trying to give you a picture here. Everything is on hold right now because a federal judge ruled in June 2024 that CMS had to re-review its waiver. And one of the questions was whether Indiana can actually use premium payments into the power account. So it's all on hold right now. Okay, so this is just telling you where we are. All right, so now let's think about autonomy in the context of HIP. Okay, so I've given you sort of autonomy in a bioethical context. Now I'm trying to think about autonomy in the context of HIP. So different idea of autonomy. Here, autonomy is sort of the ability of rational choosers to maximize utility or maximize what they see as health benefit in an economic space by comparing the costs of different health plans or the costs of different health care, right? But it's still an autonomous chooser at the center of this, okay? So different notion of autonomy, different setting, but I want to suggest there's some commonalities here too. Okay, so the way that I like to talk about HIP is there are two very different views of HIP. There's the view of HIP that its program designers have in terms of how it's supposed to work in theory. And then there's the actual practical experience of HIP members, the people who we've interviewed, the people who we've engaged, the people we've asked to problem solve the problems that they identify in a kind of participatory research mode. Okay. And for me, the easiest way to talk about these two views of HIP is the game of chutes and ladders. Hopefully you're familiar with the game of chutes and ladders. Okay. You move along the square, you hope to climb the ladder and jump up tiers, or sometimes you unfortunately hit the chute and you fall down to different tiers. Okay, so we're going to start with the program designer's view of HIP, which is the ladder view. And I don't mean that TT, I mean that DD, right? The ladder view of HIP. Okay, so for HIP's designers, HIP is a personal wellness and responsibility promotion program. HIP offers temporary health coverage to help people climb the economic ladder of opportunity. This is really the understanding of HIP as it's designed, right? And part of that, crucially, part of that is developing personal wellness and responsibility, or embracing personal wellness and responsibility, or having the opportunity, right, to invest in personal wellness and responsibility. We can talk about this in various ways, but Indiana's HIP program emphasizes the policy goals of personal wellness and personal responsibility. Consumers have autonomous choices in terms of where they want to spend their money, right? To be more healthy. Choose the health plan they want, choose the health care they need, or choose other ways of staying healthy because these other things are too expensive. By exposing people to costs, we begin to help people really think about what wellness means to them and take responsibility for it. So here are some quotes that come from one of the interim evaluations of HIP before the rules changed. So consumer-driven behavior is incentivized by providing members with a personal wellness and responsibility account. That's the meaning of POWER, personal wellness and responsibility, which functions similarly to a health savings account. Requiring members to pay monthly power account premiums ensures skin in the game, motivates members to track the cost of their healthcare, and prepares members for stable jobs with commercial health insurance. This is the designer's view of HIP and how personal wellness and responsibility can work hand in hand to help people up the economic ladder. Okay. So from the designer standpoint, how does HIP align with autonomy? Pretty well. right? HIP members are motivated to pay close attention to the cost of their coverage in healthcare. This gives people new information. I didn't know healthcare was that expensive. I didn't know this was going to cost this much money. I'm going to, get a gym membership instead. This is the theory of how the autonomous chooser is working in this space. Members freely choose without coercion which plan they want. Do I want plus? Maybe basic is better for me. I'm young and healthy. I think basic is going to be good enough, right? And the more people track their expenditures through the monthly power account statements that are mailed to them, members can act to promote their health. They can complete wellness visits. There are incentives for that. Manage chronic conditions with a regular PCP, opt other ways that are non-medical to stay healthy. Right? This is the basic idea of how autonomy is supposed to work in theory with HIP. And here's a quote that I thought was kind of interesting about how individuals need a physician's advice to heighten their sense of personal responsibility and involvement and to modify their unhealthy behavior. Put in financial incentives instead of physician's advice, and this is basically what HIP is trying to do. Individuals need financial incentives to heighten their sense of personal responsibility, involvement, and modify their unhealthy behavior. Okay, that's the theory. So on this latter view, right, there's a certain idea of agency involved. Agency involves economic initiative and self-sufficiency. That's the goal of HIP, right? We want people to be self-sufficient economic agents who can secure health coverage and afford resources for investing in healthcare, right? So people start at HIP Plus, but maybe they don't think it's worth it, so they climb down the ladder to HIP Basic. A year later, they can climb back up if they choose to at their annual redetermination date. So choice is built in throughout. This is the basic theory, okay? All right, moving on. There is another view of HIP, which is the people who are on it. So we conducted a study in 2019 where we worked with 40 HIP members to sort of understand how they experience the program, problem solve issues, whatnot. This image here is a map that just gives some of the complexity of HIP. I'm not going to get into the details of it, but you first have to get HIP, then you have to connect to a insurer, then you have to use it, then you have to keep it, right? And the red indicates the things that made it hard to do this. The green indicates what made it easier to do this. That's what this map is showing here. But what's important from the perspective of the HIP members is they experience HIP as a series of chutes. It's all chutes all the way down. And they're unexpected. People don't know when they're coming. It's a very difficult program to navigate from their perspective. So I'll give two quick illustrations. I apply for HIP. I'm approved for HIP. I get a conditional approval letter that says, you've been approved. Great. Your managed care entity is Anthem. You need to pay this amount of money, $1, David, a month. You need to pay $1 to Anthem to start your HIP Plus benefits. Sounds easy. This is not easy. A lot of things can go wrong. You don't get the letter. You don't understand the technical details. You don't understand what a premium payment is. You don't make it on time. You don't have a bank account. You don't have a credit card. This is difficult, right? Well, if you don't do that for 60 days, you're dropped to HIP Basic. You're on HIP Basic. Nobody tells you you're on HIP Basic. There are these sort of questions that people experience all the time, and I'm simplifying in many ways here. Here's another example. People's income changes, especially low-income people have seasonal income that changes, but they're looked at month to month to month. Oh, your income went up last month. You now owe a higher premium payment. You could actually pay your entire premiums for a year in advance. But if you don't know your premium went up, your premiums are quickly exhausted. This happened to somebody we interviewed who said, I always went to get my inhalers at the pharmacy, and I called him up and said, hey, I need two new inhalers. And the pharmacist said, those are going to be $4 a piece. He was like, I don't have that money. So I called 911 to get his inhalers. This is how people experience series of chutes on HIP, okay? And importantly here, people don't find they get good information. They find they have confusing information. Program's complicated. There are a lot of different programs. People don't find that these skin in the game payments motivate their voluntary action so much as they don't know how to navigate this. It frustrates their voluntary action. Swimmers think consequences of coverage reductions, routine co-payments, or coverage loss place limits on people's medical options, which we might call coercion, right? And these things don't tend to promote health. They oftentimes hinder people's health. So even in terms of the criteria of autonomy, it doesn't really seem to pass muster for the people who are on it. One thing I want to emphasize here too is that administrative burdens, which is a term that's given to things like co-payments or documentation requirements, or the new work reporting requirements that were passed at the federal government level in the new big beautiful bill. These things have learning, compliance, and psychological costs for the people who have to navigate them. Administrative burdens don't operate singly. They tend to multiply. They tend to stack up. I lose my HIP benefits. I'm now on basic, or I lose my plus benefits. I'm now on basic. Now I have co-payments. Everything gets harder. How do I figure my way through this, right? How do I bump back up again? And so one of the things that I think we really see out in the field is that sometimes people experience these hurdles, not just as individual hurdles, but as hurdles that add up. They get higher and higher and higher. And so, let's do the wrong click. I'm a Mac user. I'm not used to this fancy left, right click. Anyways, here's just an illustration of different levels of hurdles. So back in 2018, under the old rules, African Americans were disproportionately more likely to be on basic compared to plus than white enrollees were. In other words, African Americans on average had higher hurdles to accessing care. Well, that's just your choice. You can't choose HIP basic. HIP basic is not a choice. You only get on it by default. When I apply, I can't say I want HIP basic. You can't. It's not a choice. It's a default second best option that is presented in the guise of a choice. And this has real consequences for how people are treated. We had a lot of talk about, even from navigators are like, well, the clients just prefer basic. I'm like, I'm sorry. They're not choosing it. But these narratives matter, right? These views of autonomy, really how we theorize autonomy shapes how we understand people and treat them. This is the thing that I want to suggest today. Okay, so again, from the HIP members' perspective, HIP is a series of shoots. Some people do very well at it. Let me not minimize that. Some people figure out how to navigate this, get great benefits, do a great job on it, right? But some people have more trouble. So I want to indicate that some people do really very effectively on this program. But from the perspective of our members, agency is effective use of available health and healthcare resources in line with one's self-concept. That's what agency is. And here I'm kind of thinking about somebody named Gary Gunderson, who puts agency as one of the leading causes of life in one of his books. And for him, agency is the human capacity to choose and do to move toward life. And this, I think, is what we really see when talking to HIP members. Okay. So I'm moving quickly here. I've given you two quick snapshots of autonomy in a bioethical context and autonomy in the context of HIP as it's understood by its designers and then as judged by its members. I am now going to move to my third and final setting, which is the research that we have been doing as a team. This is what we call community valued research. Here I'm using a term that comes from my colleague, Ivan Douglas Hicks, who's a pastor here in town at First Baptist Church, North Indianapolis. He's also the founder of the Africological Institute and has a doctorate in African American Studies. And he and I have been working together for 7 years with countless partners, and we have another partner on a more recent study, Dr. Elaine Hernandez, who's a sociologist down in Bloomington on a Robert Wood Johnson Foundation funded study. So we've been doing this work, and Dr. Hicks has coined this term community value research. So I'm going to say a little bit about what we mean by community value research and then talk about what autonomy looks like in this setting. And here I'm going to be introducing a term called relational autonomy. So this is a view of autonomy that's been very much talked about, particularly by feminists and by womanists. Womanists are Black feminists. And so sort of thinking about a different view of autonomy that's called relational autonomy. So that's what I'm going to try to do. That's what I'm going to try to do next. So very quickly, this is the 2019 study we did. You can see the local community partners, First Baptist Church, North Indianapolis, Shepherd Community Center, also Heron Communication was here. This was a qualitative study. I've kind of talked about it already. But we really were just trying to engage with HIP members to understand what was working or not working about the program and engage in problem solving. More recently, I've been part of a Robert Wood Johnson Foundation interdisciplinary research leaders study called Examining Racialized Burdens, Medicaid Changes in Indiana. These are the three principals. These are our funders. There are many, many people who've been involved in the study. There are over 30 people who've been involved in the Robert Wood Johnson Foundation study. And I want to hold up in particular our community leadership board. We have a leadership board from different cities around the state who agreed to work with us to help us implement the study, redesign the study, think about the data findings, sort of test their validity, test their relevance, think about how to message these things, figure out how we wanted to disseminate, communicate, all of this. And so this community leadership board has been absolutely central and instrumental to what we're trying to do. And this is really crucial to what we think about in terms of community value research, okay? We've done 100 in-depth interviews around the state, racially samples, equal samples of African-American, Hispanic, Latino, and white participants, just to try to, we didn't include all ethnicities in this, but we tried to include at least a balanced sample. We worked through the community leadership board. Anyways, I'll say a little bit more about methods in a second. So community value research. For me, there are sort of two cornerstone commitments to community value research. And this is similar in some respects to what people call participatory research, right? But we want to draw out this idea of value in particular. So the first commitment from my perspective is community value research values community participants as experts. We're not coming in as experts. The community is the expert. We're working with the community not to sort of see how things are working at a population level, but to learn from them because they actually have the knowledge. Learn from and with. It's very much an iterative process, right? So what does this mean? This means you have to fairly compensate people. Community leadership board is compensated, right? It's got to be part of the study. So are the participants, right? Because you want, but in addition, you want to honor people's cultural intelligence. What do they know on the ground in terms of practical know-how? How to navigate HIP. I don't know how to navigate HIP. These people figured it out. Like, I need to learn from you. But also, a community is not a monolith. So there are always diverse perspectives in communities. So this is part of what community valued research is about too. And then importantly, it's embracing community priorities in ways that change your study. These are our priorities. What are your priorities? Oh, we need to start to change our priorities to work with your priorities. So this is part of community value research. And I'm going to give a quote from a womanist ethicist who's thinking about, she's not using the term community value research, but I think she's saying something that's quite similar to what we're trying to do. She's talking about, you know, how can we include more voices? And as a woman, she's particularly interested in Black women. She says a practical strategy for intellectual humility as bioethicists is to make space at our professional tables and within our classrooms, research protocol planning meetings, and hospital ethics committees for the voices, bodies, and perspectives of Black women. And in particular, she's talking about Black women who may be sort of more marginalized or economically disadvantaged, right? Or culturally located in ways that don't give as many privileges. And so this is, in some sense, what the Community Leadership Board is all about, right? How do you create a practical space every month to get together, to talk, to iterate, to redesign, to sort of toss out what we think we're learning and find out actually that's not the point at all, right? So it is very much this effort to create spaces for valuing the community and making sure what you're doing is actually valued by community members. And this is the second commitment of community valued research as I understand it. The research has to be valued by community members. In some respects, this is the harder one, I think, because most research projects, including ours, start with universities asking the research question. Ideally, the community would ask the research question, and that does happen. It didn't happen in our cases, but it does happen. But even when the question is brought, there has to be this kind of ongoing dialogue, iteration of study questions, methods, findings, dissemination. This iteration is so important. Try something, redo it. Try again, redo it. refine, change, adapt, adopt, right? And ultimately, the goal is to ensure the study has community relevance, validity, and action outcomes. These are not the research priorities that come from the university. The research priorities that come from the university tend to be rigor, disciplinary impact, and financial and ethical compliance for good reasons. I'm not saying these aren't good values. They're also good values, but they're value tensions that arise in this kind of research that absolutely have to be navigated. So here's another quote that I think kind of captures this broader idea that research has to be valued by community members. This is Cheryl J. Sanders, another womanist ethicist. She says, ultimately, the ethical question is not so much a matter of African-American perspective. It's not that we need more bioethicists who are African-American or African-American women, as it is a matter of African-American participation and inclusion. Perspective suggests a particular point of view, an angle or approach, while participation assumes an unqualified stake and role within the whole discourse. Are we interviewing people to hear their perspective and aggregate different ideas together and feel like we've done a better job? Or are we actually trying to empower people to participate in knowledge production that changes what we know? This is a very different level of engaging with community participants, I want to suggest. It's aspirational. We don't meet it all the time. Probably, don't get as close as I would hope we do, but it is really important when we think about sort of the aspirational goal. Okay, so what does all of this have to do with autonomy? I guess there's one more thing I forgot on the slide. So, for Dr. Hicks, community valued research, community is the source of expert knowledge, co-designer of the research, and beneficiary of action outcomes. And I emphasize action because research for discovery is not enough. There's got to be action. There's got to be action that the community wants to see. All right. So what are some of the research methods we've used? And I'll just say on the right, this is the cover of what we call our panoply of Medicaid advocacy tools. This is an open source document of all the different kinds of advocacy that we've engaged in, with an introductory statement by Dr. Hicks and some statements by me. Check it out. It's at africological.com. You can also find there the economic impact report that we wrote about HIP, where we presented the fact that in 2024, each HIP member cost the state $667 to insure for the entire year. For those of you who know how much health insurance costs a year, $667 for the entire year, Indiana pays with this federal match. None of it comes from general tax revenue. It comes from tobacco tax and hospital assessment. Like, this is the best way to invest in people's health we can think of, okay? All right, but we did a lot of different research methods, in-depth interviews around the state. We try to recruit in fast food restaurants sometimes through partners as well, participatory problem-solving focus groups, the community leadership board. I've said how important they've been. We also did community health equity consultations in each of these cities that the community leadership board organized so we could hear other voices in those communities about what health equity looks like there. We did a faith community consultation that turned into a documentary. This panoply includes a friend of the court brief, which has been submitted to the DC District Court of Appeals, where the case around HIP is currently pending. It cites our 2019 research in a number of key places. So community voices are being amplified in the halls of justice right now. It includes State House testimony. It includes all kinds of things, including poetry and art, because how do you communicate? Poetry is a communicator, art is a communicator, right? So I encourage you to check these things out. But back to the question of autonomy. So for me, as I think about what we're trying to do in community valued research, is we're trying to engage people in their relational autonomy. So relational autonomy is a different way of thinking about what autonomy means. That basically says we develop our capacities for autonomy through relationships, through the web of cultural relationships we're part of, through social relationships, social contexts, right? So we develop competencies for autonomy in these ways, but we also develop our self-concept through through the sort of relational space that we find ourselves in and where we find ourselves. Okay. So here's a kind of a thumbnail trying to say, well, is relational autonomy? It comes from a book, Relational Autonomy, Agency in the Social Self. Relational autonomy is premised on the conviction that persons are socially embedded and that agents' identities are formed within the context of social relationships and shaped by a complex of intersecting social determinants, including such as race, class, gender, and ethnicity. Probably including isn't in there. That's probably my mistake. Sorry. I might add social determinants of health too as an important thing to think about in a health context, right? But what does this mean? What is relational autonomy? Relational autonomy is developmental. It's not just asking what somebody wants in a specific setting at a specific time based on their views. It's asking, how did people develop their capacities for autonomy over time? And how do they develop their self over time? But also, relational autonomy is contextual. So the first thing to say is we need to care not only how a person exercises autonomy in a decision-making situation, like a healthcare encounter, for example, or consenting to a research study, but more broadly, how a person develops capacities of autonomy, like self-trust or not, and a self-concept throughout life. The second thing it means is when exercising autonomy, people don't simply apply their desires, goals, and values to a current choice. Their autonomous personal considerations are shaped by the social relationships that they're part of. Those might be how family has influenced them or people in their lives have influenced them. But it also is what moral obligations do they have to other people? That makes a big difference in the choices we make as autonomous people, is what are our obligations to other people, right? It is also shaped by social context. What is the web of cultural norms that you find yourself in? The narratives that shape your life, the various attributions that shape your identity, whether they're positive or negative. And it also depends on social conditions. What are the socioeconomic, environmental, and other conditions we find ourselves that either advantage people or disadvantage people relatively? This is what I think we are beginning to sort of learn from people in the setting of research interviews and these broader consultations and whatnot that we've done. So I'm going to give a sample from somebody I interviewed in an in-depth interview. And just before I get into that, I just want to preface to say that we're doing interviews with people who are on the HIP program. And these interviews can get at pretty difficult truths sometimes. The questions are probing. And so for me, it's incredibly humbling and awesome when somebody shares a story with me about intimate, difficult details in their life in a one-off interview with a white researcher who's just showing up for the day, right? I mean, we try to build relationships through our community partners, build a level of trust there, but that's the situation. So we really need to name the setting for what it is, at least in these interviews. So this is a story that was shared to me by a woman we're calling Nina. That's not actually her name. And this is how she starts. She says, I'm a Black woman. However, this is in response to the question I asked. Have you ever experienced or seen people being treated differently or unfairly because of who they are? That's the question I asked. And this is a hard question to answer, as you can see by sort of her gathering her thoughts. However, and people tend to try to stick at me sometimes. I just, because I feel like I do have to stick up for myself, but I don't want to turn into the angry Black woman. So I always try to keep myself on an even keel because people do try to, they do try to get snippy with me or try to make me feel less than. So she's describing, I think, in pretty powerful ways, emotional response, reading how a person is responding to her. And then she continues to say, well, what do I do? She says, when I approach the desk and they find out I have Healthy Indiana, they don't want to give you eye contact anymore. They're short, their demeanor changes, but mine doesn't. I continue to be kind. I continue to smile. I can continue to keep my voice the same. And I try to take a deep breath because now they want to treat me differently because they see my insurance. then I feel like they see my temperament and the person that I am, and it kind of soothes them. I kind of hate that I have to be that way, but my older sister always tells me to be true to my kindness and don't let people's attitudes change who I am. I think this is a very powerful statement, but also a really important way of understanding what does relational autonomy mean. She's telling her story as a health seeker who's trying to get healthcare through the Healthy Indiana Plan, right? She starts by talking about social relationships. Well, she doesn't start by it. She talks about social relationships. She has a very important relationship with her older sister. You're a kind person. You have fortitude. This is part of her self-concept. She has found herself and who she is through her relationship with her sister. And she's going to carry out who she is in her relationships with other people, including some unknown stranger at the desk who's looking sideways at her, and including a white university researcher who's interviewing her, right? Social relationships is one of the ways that we develop and engage our autonomy. What about social context? The angry Black woman trope. This functions to survey and police this woman's behavior as a cultural story that she's not going to fall into, even as she has to work very hard to dance around it. This affects decision-making. This affects rational, free decision-making. This affects autonomy, right? There's a whole social cultural story here, a whole cultural way of expectations that are at hand. The HIP card, as soon as you show the HIP card, a whole narrative starts. Oh, you Medicaid people, not responsible, not taking care of yourself. What are the cultural attributions that go with that? What are the cultural assumptions, negative norms? And on the other hand, positive norms that people might get with other kinds of insurance. Social conditions. When the woman got on HIP, she was between jobs when she applied for HIP. This was during the pandemic. She's never experienced HIP with all the usual rules. She got on HIP Plus, stayed there, thought it was great, loved it. It's just these encounters that she has sometimes that make it difficult for her. Her agency is very much helped by HIP without the hurdles, but it is still an issue to navigate her agency in these spaces. Okay, so hopefully this gives some illustration of what relational autonomy means. I'm going to bring it home here. I realize I'm kind of going on a bit, but I've tried to offer 3 ways of theorizing autonomy in 3 different settings. I will admit less form for me is my alternative, which is a notion of agency. So maybe we can theorize agency together. That's really in some sense the next step. But I do think how we theorize autonomy affects how we understand people and care about and for people. The different settings matter. The setting of a clinical encounter, a health research study, or the setting of HIP, or the study of community value research. These are all different settings. They have different institutional contexts that come with different conditions, different cultural expectations as well. So HIP's designers have confidence that HIP promotes autonomy. HIP members don't think it does. I want to suggest that the standard view of bioethics, standard view of autonomy in bioethics, also can fall short in some ways. Standard view of autonomy in bioethics, I think, is too narrow in trying to protect and support voluntary choice. So let's minimize, I think this minimizes how much cultural and social forces of coercion are at play that bear upon the clinical encounter, right? But also barriers to quality actionable information, like we see in the example of Nina. The focus on in the present situation, what's the healthcare decision today, abstracts from the social supports and conditions that people have that support them or that maybe are barriers they have to navigate. And I want to also suggest that it also presupposes that people have access to the clinical, the research, or the commercial setting, when in fact many people struggle to have access. I think this view of autonomy keeps us from asking, how do people get access? How are people helped in getting access, using their relational autonomy? And maybe this is why Medicaid isn't talked about much in bioethics. Maybe this is sort of the barrier. I also think that healthcare practices are evolving. There's now social assessments and clinical intakes. This reflects relational autonomy, I think. Community health workers are trying to tailor services to people. I think healthcare is actually evolving to something that's a more robust idea of autonomy. And I'm encouraging bioethics to consider doing so. I'm done.
Nick's gonna manage the.
Yep.
And in the room though, we have a microphone, one mic here and seats. Behind them.
Thanks for the presentation. It's also so nice as someone who I see a lot of patients with it, and I think these stories are really they're appreciated. I think we know this administrative burden put up, what that entails, the kind of the rationale behind that. Yeah, so thanks for that. I'm imagining that potential counter argument, like at this conclusion here, is that that yes, autonomy is too narrow to do these things, but thankfully we have other principles that we, right? Like, so when I think of things like health promotion, I actually, in my mind, I'll have to, thanks for showing that. I'll have to go back into that section because I think of initially, like I think of beneficence, I think of justice as sort of the actual driving principles often behind that in ways, but so I think maybe that I'd be curious to see what your perspective is on someone saying like, yes, but this is autonomy. We have to use these other principles to balance, right? To arrive at the thing you're seeing. And I think it's like theoretically like challenging, and then also practically, right? The practical challenges that you're identifying. But yeah, I'd be curious.
Yeah, no, I appreciate that question. The four principles, right? It's not one, it's not just the autonomy leg that we're standing on. We're standing on four different legs, right? And I will say that the arguments that come from bioethicists around health insurance tend to be supporting universal health coverage, usually for justice reasons, right? So we do see that. Certainly beneficence is a way of thinking about, health promotion in addition to sort of supporting people in more immediate senses. But I do think that autonomy carries this view of self-concept. And we really see that starkly in, say, reproductive health, for example, right? Or refusal of medical treatment. And for me, the divide, like we're doing autonomy now. Now that we've done our autonomy thing, now we're going to do beneficence. Like, I think it needs to be more integrated. And sometimes, autonomy can turn into a checklist. Have I provided all the full information? Have I clearly communicated? Does the person seem competent? Are they being coerced? No, 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 no. We're good. That worries me, just as it worries me in the research setting. We do informed consent with our participants. I say, I want to make sure people are fully informed. They have a sense of the risks and benefits. They're making a voluntary choice to participate, but I'm not done at that point. I really haven't fully engaged them yet in their autonomy. So I hear you, and I will admit that's a question that was niggling at me as I was writing this talk. So thank you for articulating it out loud.
Yeah, no, but I think the agency aspect of it is really fascinating. I think it's perhaps a better way of thinking about that, right? Like, what is the next step, right? Before I have to, like, get rid of it altogether, but like want to also account for the other things being hard, like that's justice. Because as you're also suggesting, is that the way in which something like it is designed is like is not thinking about it, right? It's they are kind of folks essentially by the agency, but it just reminds me of kind of the pediatric ethical situations often,
Mhm.
people with burgeoning autonomy.
Mhm.
So they call it
Mhm.
burgeoning autonomy. But also global health ethics. You
Mhm.
know, I think when you hear this a lot, what do you mean? Is the center of all of this.
Mhm. Yeah, thanks for that question.
I'll ask one, and then maybe we'll go online. So Dave, it's fascinating work, really important. Just love the talk, thank you for doing it, and actually the educational part. That I also like Josh. I practice general internal medicine, and I do Eskenazi, and a lot of my patients have to have. So it's nice to learn. A lot of kids do to me. So it's I'm sure it's true for all people listening to your talk. I'm fascinated just throughout chewing on the question of responsibility. And I love the chutes and ladders picture. It looks like chutes and ladders, looks like ladders to the creators. It's like chutes to the recipients. And I was also thinking about the anger and the dislike of Medicaid. Partly based on just misinformation about the expense, but also partly based on feelings of people about lack of responsibility, right? Like you said. And how do you think about your work, both theoretical and empirical? How do you inform that conversation? I know you're working on trying to get it protected, but gosh, it's just how do you address a change in thought about responsibility and its role in healthcare? I don't know how to find that question.
Sure. Well, the question was, I'm going to boil it down to its essence, which is how do we think about responsibility in healthcare, particularly the ways that responsibility is thought about in HIP may not actually be very productive. And maybe that's not saying it quite right. But I mean, there's sort of a theoretical level to this, and then there's an empirical level to this, right? The theoretical level is personal responsibility is an ideology. It's a set of ideas that hang together. And this is very much active in the Big Beautiful Bill Act because personal responsibility is central to the cuts that are coming to Medicaid. The projected cuts to Medicaid include about $250 billion over the next 10 years because of work requirements. We call them work reporting requirements. If you include the people who have jobs, up to 20 hours, if you include people who are caregivers or students, that's 90% of the people on HIP. All of these people pass the bar, but they still have to report. This is not a help to personal responsibility. This is an administrative burden that gets in the way. And I see the ideology of personal responsibility as having three levels. The first level is, do people have personal responsibility for health? Well, you know, to the extent that we should try to make effective use of available resources as health seekers, yeah, but does that mean I'm responsible for, you know, the COVID I got? No. I mean, so, but nevertheless, we could talk about a kind of level of personal responsibility as agency, health seeker agency. But the next level is you're responsible if you deserve it. Well, I'm responsible because I work a productive job, so I get healthcare benefits. I'm deserving. I'm responsible because I'm deserving. Well, maybe HIP members aren't really deserving, but they could prove that they're deserving by paying their monthly premiums, right? And then the last level of personal responsibility is, and if you're not deserving, we're going to discipline you because you need to be disciplined. So we're going to kick you out of coverage, or we're going to downgrade your coverage to teach you to do better. So we can think about personal responsibility in health as agency. We can think about it in terms of desert, or we can think about it in terms of discipline. And I think all three of these things are going on in the political debate. And I can tell you the HIP members know this. They get it. I got this from the HIP members. I didn't make this up, right? So from an empirical standpoint, it's trying to hear what people know and to try to channel that. But there also has to be a kind of community level of talking about this at the State House. And I mean, I will say, maybe I'll go to this slide here just to show, like, these are some of the things that are coming in Indiana Medicaid. Now, importantly, a coalition of advocates beat back two things that were coming. One was to put a cap on HIP at 500,000 people when there were 700,000 people on it. They were just going to presumably arbitrarily remove 200,000 people from the program, but also set a 36-month lifetime cap on the program, which is simply not viable for people. Those two things were stripped out, but other things are coming. There's going to be frequent income and eligibility reviews across Medicaid that happen at least quarterly, if not more often. This is what disrupts people's care. Oh, you had a higher income last month, or we have a different record than you're reporting. Send us these documents. People don't get the letter. People can't send the documents. They can't track down their old boss who fired them. All kinds of things happen. Care gets disrupted, coverage gets disrupted, right? More frequent redetermination and documentation, communication barriers. These are all things we saw back in 2019. But here's what's new. There's now a gag order on advertising. You're not allowed to advertise Medicaid anymore. You can't advertise it. You can't tell people, hey, you know, all the buses with Anthem, get HIP, those are gone. Can't do that anymore. Certified navigators can't navigate. I mean, there's no advertising of the program anymore. So this is going to decrease awareness. We've got these new reporting requirements for people that I've already mentioned. And people are going to lose their exemptions because things happen bureaucratically. It just happens, right? So then they're going to have to recertify and all of these sorts of things. This is now coming at the federal level too. So the new bill has passed a work reporting requirement for all states across the country that they have to implement. In addition to these funding cuts, which are anticipated to be covered by people losing coverage because of work reporting requirements. It said, well, this is fraud, abuse, people who don't qualify. That is not what we find in research studies.
You have one question online.
Okay.
What has been the state legislature response to research on HIP implementation?
Yeah, so in some sense, I was talking about that. Huh? Oh, sorry, I have to repeat it. What has been the state legislators' response to our research on Medicaid impact and HIP? Okay. Yeah, so we have presented, so we wrote an economic impact report, which we tried to circulate. It actually became a talking point in the committee meeting, the Public Health Committee in the House, where we were testifying as well. That $667 per person became a central talking point here. I mean, I'll give you another interesting illustration too, which is one of our research team members, Wade Catt, who's a medical student here, was talking about the 2019 study. And he said, you know, this study engaged 40 experts on HIP and sort of went on and said other things. At the end, one of the legislators said, who were the experts you talked to? And Wade Catt clarified, these are members on HIP who are participants in the program. And the guy said, oh, I thought you said experts. And Wade said, no, in community participatory research, the participants are the experts. And those people had just been testifying, telling their stories. And suddenly the legislature was like, oh, I didn't mean it that way. But like, this is so important. Who we interview authorizes people as public experts. Who we quote authorizes people as public experts. As researchers, we are authorizing public experts. And it is a radical act to say HIP members are experts, public experts. And so in some sense, I think our research has been less dramatically important than the stories that the experts have to tell. And to the extent that we can sort of amplify and sort of do a film documentary that shows some of this, right? Or videos that do some of this, or have poetry that tries to get people to